Sheldon.
All right, folks, I'll go ahead and kick us off, and then I'll keep admitting folks as they join our quarterly meeting. So welcome, everybody. My name is Bahia Manasra. I'm the Operations Director for Healthcare for All Minnesota, and I'll be helping to guide tonight's discussion and being here as a support person if you have any tech-related needs or any questions along the way. I want to welcome you. I'm noticing just by the participant list, we have quite a few people who I think this may be one of their first quarterly meetings with us because their names are new. We had some great outreach over the summer, and so we know our membership base has been steadily increasing. So if this is your first quarterly meeting, we're extremely happy to have you with us tonight, and we hope you learn a lot and find this meeting fruitful. I just want to go through just a couple meeting norms before I pass this over to Anne to go over our agenda. Just a few reminders. Please make sure that if you're not speaking, you stay muted. We just want to make sure we can minimize distractions as much as possible. There will be a Q&A towards the end. So if you have any questions, you'll be able to come off mute and ask any questions you have. Throughout the meeting, the chat is enabled, so you can ask questions in the chat. Myself and others are more than happy to respond to you throughout the meeting. And then for your video, we love to see people's faces. It helps connect the name to the face, but we understand it's the evening. Some people are just getting home from work. They may have dinner on the stove. So we understand that folks may be multitasking and it just might be easier to have the videos off, which is perfectly fine. Do what you have to do to be comfortable and participate as you're able to. With that being said, I'll go ahead and pass this over to Ann Jones.
Thank you, Bahia, and welcome everyone to our September 25th, 2025 Healthcare for All Minnesota quarterly meeting. I'm Ann Jones. I'm a retired registered nurse and vice chair of Healthcare for All Minnesota. And I want to echo what Bahia has said and say that in the face of all that's happening right now in this country and probably in your lives, we thank you for signing in this evening and being willing to spend some time on this issue of health justice. Our presenters this evening are Bahia Manasra, our Director of Operations for Healthcare for All Minnesota, Rose Roach, Chair of Healthcare for All Minnesota and National Coordinator for the Labor Campaign for Single Payer, Sheldon Toubman, attorney, disability rights and legal assistance, coming to us from Connecticut, and me. And our agenda is some remarks from our chair, Rose, to kick us off, and then we will hear from Mr. Toubman, who will talk about how Connecticut eliminated capitated managed care in Medicaid, a fancy term for removing the insurance industry from one of our public health insurance programs. We will follow that with some time for our question and answers. And then Rose is going to talk about one of our top legislative priorities here in Minnesota, the Patient-Centered Care and Direct Payment to Providers bill. I want to thank our volunteers and make some announcements and talk about upcoming events. And then Bahia is going to talk about fundraising, which is really important for our work, to support our work, and then we'll wrap it up. So, Rose, go ahead and get us started with some information from your point of view.
Great. Thank you, Anne, and welcome everyone. Good evening. Glad to have you here at our fall Healthcare for All Minnesota quarterly meeting. You know, so much has changed since the last time that we met, especially within the healthcare sphere. H.R. 1, the GOP budget reconciliation bill, was passed and signed into law on July 4th. That bill does serious damage to an already damaged healthcare system. To be clear, whether or not you access healthcare through Medicaid or Minnesota Care, or you purchase your insurance through the MNsure Affordable Care Act exchange, you will be impacted. With hundreds of thousands of Minnesotans expected to lose access to care due to H.R. 1, we will see uncompensated care increase as patients use emergency rooms for their healthcare needs and hospitals working with insurance companies to get the compensation from somewhere, and that somewhere is likely to be paid by every one of us via double-digit increases in our insurance premiums. We're already hearing that employer plans across the country are going to increase more than they have in the past 15 to 20 years. Double-digit increases. Medicare Advantage and Medigap premiums are expected to increase, and likely increases are also going to come in the form of out-of-pocket costs such as copays and deductibles. Rates on the open market are anticipated to rise even more so, as much as 25% here for the MNsure plans in Minnesota. MNsure recently stated a 50% increase on just premium costs due not just to the increases that the insurance company will place on those premiums, but also due to the loss of the advanced federal tax credits, meaning it's likely we will see our uninsured population increase here in Minnesota as well. Couple that with the recent announcements that I'm sure everybody has seen of Mayo closing clinics and UCare exiting the Medicare Advantage market, and we can clearly see the serious cracks within a system that continues to center profits over patients. Later in the meeting, I will walk through our other impacts of this disastrous law with an eye on an opportunity to mitigate some of that harm that's headed our way. As Churchill once said, never let a good crisis go to waste. Healthcare for All Minnesota has been busy this summer. We have been doing targeted one-on-one meetings with various legislators, laying out the argument for Medicaid and Minnesota Care to be deprivatized, meaning removing the private insurers from our public health programs as a means for realizing significant savings that can then be reallocated from unnecessary private insurer waste to direct patient care. A significant part of tonight's meeting will focus on the importance of public health program deprivatization, spotlighting our friend and fellow activist, Sheldon Toubman from Connecticut. Connecticut deprivatized their Medicaid program over a decade ago, and Sheldon will provide insight as to how and why they deprivatized and the success that they've been experiencing for doing so. These one-on-one legislative meetings that we're doing are critically important. We simply must work together with legislators to develop an inside-outside strategy that begins moving stepping stone legislation towards our gold star, which is, of course, the Minnesota Health Plan. It's difficult right now. There is so much to do on defense that it sometimes feels somewhat useless to be focusing on offense, but it's critically important that we do so. We cannot argue to go back to the status quo. In healthcare, that was literally killing people and was and is economically unsustainable. We must strive to mitigate harm, but to also provide a vision of what is possible. A bread and butter issue that remains a top 3 issue of concern amongst the vast majority of Minnesotans and Americans across the country: healthcare accessibility, affordability, and quality of care. It's time to take it on. We know what needs to be done to fix this system. We must now band together to demand to get it done. I want to close with a quote from an August 2nd article in the New England Journal of Medicine. The article was entitled "A Gilded Age for Patients: The Broken Promises of Profit-Driven Medicine." It was from a series called "The Corporatization of U.S. Healthcare" by Nancy Tomes. Nancy said, quote, "No market solution has arisen for the most critical determinant of poor health and healthcare outcomes in the United States: extreme income inequality. The Trump administration appears intent on blowing up our fragile healthcare system in the name of an unrestrained free market and corporate profiteering. Many people will suffer if the system collapses completely, but perhaps a more sustainable healthcare system can be built from the rubble. Together, let's build that sustainable, humane, caring system." Thank you as always for being here. You're in for a real treat with our keynote speaker and opportunities to engage in the campaign to win healthcare justice for all. Thank you.
Thank you, Rose. Next up, our speaker is Mr. Sheldon Toubman, who is a litigation attorney with Disability Rights Connecticut. Mr. Toubman has decades of experience advocating for Medicaid enrollees. And everybody knows Medicaid in Minnesota is also known as medical assistance. So same program, including more than 30 years with New Haven Legal Assistance Association. At Disability Rights Connecticut, he works on behalf of people with disabilities through litigation, legislative advocacy, and public education. He has been a leading voice in exposing the risks of privatizing Medicaid, which means outsourcing managing our Medicaid medical assistance beneficiaries by the private insurance industry, and promoting community-based alternatives. Mr. Toubman will share insights from his extensive work and discuss the successes and challenges in the fight to deprivatize Medicaid. Thank you, Mr. Toubman. I'll take my slides down and you can bring yours up.
Okay, thank you very much. We did this before, and hopefully I can do it again.
Stop sharing that way you can.
There we go. Right. Okay. And okay. I hope people can see that.
No, we're not seeing it yet.
You probably have to hit the share button on the
Yeah.
bottom of your screen.
Yep.
First
There.
share, then we are starting to see screen sharing, and then
See it?
slideshow,
Yeah. Slide.
and then from the beginning.
Right.
There you go. Thank
All
you.
right.
Ron.
Great. Well, thank you very much for inviting me. I did want to say in response to what Rose said, this may be an opportunity. I'm hoping it's an opportunity where the fact that we are all in defense can be turned, is it jujitsu? Is that what it's called? Into offense, and it's linked together. And you'll see when we get to talking about the decisions for a National Health Program report, that's really the focus. But we're going to start with talking about sort of the history in Connecticut, how we did what we did. And it is a story of how we went to manage fee-for-service in place of capitated insurance, risk-based insurance companies who were told, you do it, here's the money per member per month, and basically, oversimplifying, don't bother us, it's on you. Okay, so just a little background. I know this is like 101 for some, but just so we understand, Medicaid is a state or a territory's program providing healthcare coverage to low-income families and individuals in different categories. We call it Husky, you call it medical assistance. Managed care organizations, or MCOs, are hired by some states, actually most states at this point, to run their Medicaid programs. They are private or nonprofit. I should say private, either profit or nonprofit insurance companies, and they're paid on a per member per month flat fee to cover all necessary care. Sometimes they're not 100% of the responsible for the body. They're only responsible for most of it. But anyway, to provide for the care needed for the person, and that system is called capitation. If the cost of care are lower than the state's payments, the MCO can keep the excess profit. And of course, that creates a direct incentive to deny care because they get to pocket the money. Now, the MCO industry and their supporters say, well, actually, that's not true because we have an incentive to keep people healthy because after all, we're responsible for everything, including the hospital care. So if we don't keep them healthy and they end up in the hospital, that's on our dime. So we are totally motivated to keep people healthy, which sounds plausible, unless you realize how it really works. First of all, for for-profit publicly traded companies, United Healthcare, et cetera, they look at the current quarter, like how much money we're making this quarter, and that's really all they care about. So keep people healthy and avoiding hospitalization in a year or two is like not really a thing. And in addition, there's a lot of churn in Medicaid in general, but in Medicaid where people change plans. So even if they cared more about this quarter, they care about like the year. And even if there were conditions which maybe would manifest in less than a year if you don't keep control of them, if you aren't proactive with preventative care, they may be in another plan by then. So you don't get the benefit of it. So these are a couple of the reasons why, there's others, but why the whole argument that we keep people healthy because we have a financial incentive to do so just doesn't work. MCOs have very high overhead. And that's beyond profits. So they could be a nonprofit, but they still have high overhead. And that includes marketing budgets. There's always multiple MCOs, so they have to try to get their market share. So they spend a lot on marketing. They have high executive salaries, and all of this is redundant, right? Because they're all doing the same thing. Of course, if you believe in the free market and you believe you have to competition, you might say yes, but that's worth it. In this sphere, it isn't. So I have to learn how to operate this thing. So our history is that we first hired MCOs in '96. Right away, it was terrible. We noticed there were no notices when people were being denied services. And so we sued the state and one of the largest MCOs to force compliance with the federal due process requirements. We also had problems where the MCOs had their new enrollments stop because they just didn't have providers to, even by the state's reading of it, which was very liberal, they didn't have enough providers to warrant it, so they would stop enrollment. And then we started getting into doing secret shopper surveys. That's where tests are done to see people pretend to be a patient to probably get an appointment. And this is what we found. The study found that 4 of 10 providers listed by the MCOs did not take any MCO patients. 1/4 of the time only could people can get an appointment. So they didn't participate in the Medicaid program. They don't participate for the managed care part of the Medicaid program, or they don't participate for that particular provider, that particular MCO, or only take patients they've already had. Or sometimes the doctor was dead, which made it hard for them to take patients. But that was what we found when we did that secret shopper survey. The other thing we had is just, and I'm sure you have this in Minnesota and elsewhere, or I shouldn't say, I don't know for a fact you have this, but in general, MCOs, especially if there's a relatively small number, we started with 14, and then we got down to 4, and then we got down to 3. When you have very few, there's tremendous power. If the state is afraid of losing the system, they're terrified if an MCO threatens to leave, and that means they can get more money, and they always negotiate to do so. So we just, in the slide also, we had a time when the state was trying to get a special tax break to MCOs on the commercial side of their business, and they were forced to reveal why. And the why was because they want to pay them more in capitated rates. But the problem with doing that is CMS, the federal Medicare and Medicaid agency at the time, maybe even today, I'm not sure, but at the time, they wanted to make sure that the rates being paid were like not more than it would cost to not have them. And the state admitted that if we paid them more in capitated rates, we might go over what CMS would allow because we'd be acknowledging it's too expensive. It costs more to have them than not have them. And so they tried this backdoor thing with tax break. That's the kind of thing that happens when you're under pressure to keep these companies happy. They always claimed they were doing managed care. They were never actually doing it. They would hire nurses to hound people out of hospitals and get them out. They've had the surgery. It's time for you to go home. That was what was going for managed care. And the state couldn't get data to hold them accountable because, of course, everything is proprietary. Everything is top secret. So as I mentioned, we brought litigation early on about the lack of due process, no notices or notices that had bogus reasons in them. And that was important because having to put in writing why they were denying people did at least allow some measure of accountability. It was a start, right? But the litigation had a completely independent benefit. It was generating bad press, which insurance industry really hates. But apart from that, it helped to start educating the public and politicians that there's a problem with our system. It took years to get rid of them, but we started. And we also publicized the lack of accountability, so we couldn't even tell where the money's going. They don't want to be accountable to the taxpayers who are paying them. We also tried to get information about the medical loss ratios, which is how much of the money, the taxpayers' money, is going to healthcare. Taxpayers aren't so upset about their taxpayer dollars going to providing necessary healthcare for low-income people. That's okay for a lot of people, right? Maybe most people, but they're not so wild about it going to administrative costs and profits of insurance companies. So we worked hard at getting that. And we publicized all of this, including specific stories. It was really important to get real. That's what really gets the media's attention and the public's attention of a story of one example, a person who broke her leg, shows up at the hospital, And it's one of those situations where it needs surgery. It's not going to heal itself. Absolutely. She was in great pain. They send her home, and this is an emergency. She's got to get into see an orthopedist for surgery. Sorry, it's a week. It's more. Sorry, nobody participates as an orthopedist in your plan. And so that was a front page story. In addition, as we were fighting them, we did propose an alternative, right? You've got to have an alternative. So our alternative was called PCCM, which stands for Primary Care Case Management, which is a kind of managed care in the Medicaid Act, but it's completely different. It's where you pay primary care providers extra to coordinate care for their own patients. No insurance companies involved, no financial risk, incentive to deny care, but they're paid extra for coordinating care. We worked hard for it, but we got a tiny pilot going, and we showed that as an alternative. So then during the governor's race in 2010, we educated all the candidates equally, pursuant to 501c3 rules, about the problems in the system and how there's a better way, and how this pilot maybe could be expanded to be statewide. So then we won in the sense that the person who won, Governor Malloy, when he came in, he was interested in getting information about what's going on, and he wanted issue briefs. He set up committees to look at different various issues, and we talked to those committees. We lobbied those committees to make sure that the new incoming governor was briefed on the problems and the alternatives. So 3 weeks in to his governor, his first term, it was his first major announcement. After 3 weeks, his budget director explained, we're going to fire the MCOs. We're going to do it effective in 11 months, and that gives us time to put out RFPs to get ASOs, administrative service organizations, who will be paid on a non-risk basis to do certain of the activities of the MCOs. This is not something we asked for, but in retrospect, it was pretty smart, because the state agency was not up for taking on these roles, such as there's some provider recruitment, but the big things were prior authorization. To the extent the state wanted to do prior authorization, and they did, who is going to do that? Those involves scientific information, medical reviews. Who's going to do that? And the state kind of did not respond well to the thought of the state agency taking that over. So ASOs contracting it to somebody else made a lot of sense. But again, the key was done on a non-financial risk basis. In addition, there was an agreement to build on that PCCM model to go to broad use of patient-centered medical homes, as had been used to a small degree in that pilot, paying them extra for doing that. And the ASOs, the behavioral health ASO and medical ASO, was given responsibility for doing intensive care management for some of the clientele, some of the patients who are having significant issues, complex medical problems, spending too much time in the ER, too many days in the hospital, et cetera, to try to figure out what's going on and see if there's something we can do. But that was the agreement to do those RFPs, and those went out, and we then hired 3 companies to do it. And it's interesting is that although 2 of them were for profit, one was nonprofit, they all did a remarkably good job right out of the gate. So the conversion happened on January 1st, 2012, and the system has been maintained this way basically ever since, except that we did have a non-risk ASO for medical transportation, and that was turned into a risk contract, and you'll be shocked to hear that contract has been a disaster. So now talking about, what was going on, having MCOs, did they improve anything? What happened after we got rid of them? So I bold because this is so important. Despite many years and many studies, there was no evidence that MCOs improve access to care or the quality of care that members receive, which is constantly claimed by the industry and their supporters. And that's according to MACPAC, the major federal Medicaid oversight agency. We have among the highest measurements for quality of services. We're now in the top quarter of states in 17 of 28 quality measures and 13 of 22 child quality measures. But perhaps more importantly, it's right after the conversion, we got a lot more providers participating. Now, there was a confounding fact, which is at the same time, we increased the rates for primary care providers, and that could explain, why more providers came in, except that we didn't touch rates of anybody else. We didn't touch the rates of specialists, and yet we had a 19% increase for them as well. And we had associated, not surprising, reduction in ER usage. So we attribute this to basically the hassles that have been taken off the backs of providers when you no longer have an MCO, which does extensive prior authorization and routinely denies prior authorization. And then when a provider tries to get paid, they give them grief about getting paid, and they lose it, and then they demand something else, and providers say, I'm out of here. So that is what we attribute the dramatic increase in provider participation that we got at that point. So the other thing involved is, despite many years and many studies, there's no evidence that MCOs save states money overall. That's what they're really selling, right? They say we're going to improve care, we're going to coordinate care. What they're really selling to the state is we're going to save you money. And it's not, the evidence is not there. We, Connecticut, one of the few states that don't use MCOs, we have the best cost control in the nation. We've saved billions of taxpayer dollars since 2012 when we ended MCOs. And we're small states, like billions is a lot. We've saved roughly $4 billion since the conversion. And then there's two big issues, which how much is the cost overall, and then how much is being wasted on administrative costs and profits, fraud, waste, and abuse. And we spend about 3.8% of our program costs on administration. And some of that is for like eligibility processing. If you take that out, we spend about 2.75% of our program costs on sort of running the program, administering the program, not related to eligibility, but actually running the program. So that's a medical loss ratio of 97.25%. There is no MCO anywhere in the country that can come anywhere close to that because of their redundant administrative costs, executive salaries, marketing, and of course, profits. The inefficiencies are everywhere. It's redundant advertising, redundant everything. State agency costs to manage the MCO contracts, overlapping, duplicative functions between MCOs and state, and the cost to the state of collecting, harmonizing, reporting data for multiple MCOs, and of course, profits. That's just some of the inefficiencies. This was a slide that just shows that, now it's a little historical now, but just shows how we did in trend in our program over those few years, and you can see that we actually dropped at some point. But these are very PM the far on the far right. Those are substantial. Those are really substantial improvements relative to the U.S. Medicaid spending generally. And also our performance measures. So, we basically have adopted every innovation. That's another argument. MCOs innovate, you need us, so you can't really keep up with things in modern medicine without us. Yeah, not true. We do it without them. Let's see. This slide is very interesting. This was a study we had nothing to do with, didn't know about it until it was done and published. But we, as you know, we changed in January 2012. An enterprising researcher, I don't know how they zone into it, but basically they were looking at cancer rates or actually cancer survival rates, and they found that things started changing for the Medicaid populations in Connecticut versus New Jersey at the same time of the conversion. So it's definitely statistically significant that cancer survival rates rose 8% in Connecticut compared to New Jersey, which did not have that kind of change. And this slide has been shown quite a bit, and I think people are being reasonably impressed by it because it's sort of like it's an outcome test, right? And overall, if there's restrictions on access to care, prior authorization, not enough providers, that these are the kinds of things ultimately you're going to see. So why do states use MCOs for Medicaid? I can't speak for Minnesota, but in general, it's easier. You just contract away and they do it. If there's complaints, you go there, right? A perception, not the truth, a perception that you get more predictable budgets for the state, right? So like you just write a contract to them at the beginning of the year and you're all set. Well, really? That's per member per month. If there's a shift in the number of enrollees, that's going to make the contract more expensive. So that doesn't insulate you from that. And the second thing is, and this came up when we did the conversion in 2012, which was questions raised. This was at a press conference by a reporter saying, well, what about taking on this risk? Isn't that a big deal? And the budget director for the state said, no, it's a very large program. The risks are so spread out that actually it is very predictable, even with a few, heart lung transplants thrown in. It's actually quite predictable. So this is kind of a red herring, but it is a reason that's used. In some states, there's an ideological preference for privatization as always being better because it is, regardless of the facts, regardless of the proof on whether it saves money or not. But I don't know if that's an issue in Minnesota. It certainly is an issue in some states. And once they're installed, it can be hard to move a large bureaucracy, your Medicaid agency, to say, yeah, we'll take it over. Like, really? We're not going to do that. We don't have the resources to do that. And there may be political opposition to doing that. And one answer is the ASO model. And of course, the industry, once it's there, spends a lot of money on lobbyists to keep it that way with their arguments. If they can do campaign contributions, they'll do that. And they do advertising and sponsorships with nonprofits in order to create the false image that they're essential and to silence voices that will call for reform. So, okay, it sounds like that was good that we got out of that. Well, last year, this is new, last year, our governor, different governor, Ned Lamont, an entrepreneur by background, a wealthy entrepreneur, he made it known in early 24 that he wanted to look to a possible return to MCOs. And he argued, well, all the other states do it. What's wrong with us? Right? We should be looking at that, right? It wasn't the first time we had heard from it before. We actually heard from him saying this before he was even elected in 2018. So we weren't totally shocked, but here we are facing this, and everybody raised a lot of concerns about it. So the agency said, well, we'll look to an independent reviewer who will sort of do an analysis of our program versus MCO programs and tell us what to do. So they hired Manette Health. Manette Health is part of a law firm which represents Medicaid agencies and Medicaid MCOs. So basically, he was going to one side to say, hey, does your side work or not? So we objected to the choice of that consultant. We wrote a letter, signed our letter to them saying, don't cancel that contract and get a different consultant. So we were ignored. But the good news is, despite the obvious conflicts of interest, they issued a report in December of last year. And this is what they found right in their report early on. Connecticut has 14% lower per member per month cost than the Northeastern state average. And all the states in the Northeast, not just New England, all of the Northeast are MCO with the exception of Maine and Vermont, besides us. So basically, it's almost all MCO states. We're 14% lower PMPM than them on average. The report also said, again, a report basically from the industry's representative said that our Medicaid administrative costs compared very favorably to managed care states with total administrative costs at just 3.8%, which I mentioned before. I parentheses, there's something that's bogus in the report. They were claiming that for states, the administrative cost is 9.4%. At the MCOs, and the MCO's cost is only 5.9%. We know that's absolutely not true. And we looked into this. We know how they cooked that number. But keep in mind, it's from the industry. But the bottom line is they acknowledge our costs were only 3.8%. No MCO can come close to that. And they noted we perform about the median for 70% above the median. That's wrong. It's above the median for 70% of national adult and child quality measures. And then this quote, while Medicaid managed care often reduces medical service costs, because that's what the industry says, there is little evidence that managed care would reduce Connecticut's overall state Medicaid costs after accounting for managed care administrative spending, which they say is only 5.9%. But we'll get to it in a moment, it's much higher than that. So the recommendation from the industry's consultant was DSS should explore, that DSS is Medicaid agency, should explore targeted areas to reduce costs and improve outcomes instead of pursuing a transition to comprehensive managed care at this time. So we think we've won again. It's always a fight, but we think we've won. If we did go back, the quality of care would suffer, fewer providers would participate, we'd have all those administrative hassles again, prior authorizations, not be able to get paid after the provider gets prior authorization. Patients will lose the real coordination of care we're providing if they go to MCOs. And this will fall hardest on people with disabilities, seniors, communities of color, people with complex medical conditions. The collaborative relationships we've been able to develop with the agency would go away. We'd have a hard time getting performance data once again because it'd be a secret. It's protected, it's proprietary, et cetera. And perhaps most importantly, it would cost us extra billions of dollars, which would have to come from somewhere. So I now want to talk about the PNHP report. This is, I think everybody knows that the Physicians for a National Health Program, the national issued a thorough report on the failures of capitated managed care. And this is the part, offense versus defense. There are terrible cuts coming to the state in terms of dollars, federal dollars. We're gonna have a lot less money, right? So what are we gonna do? How are we gonna defend against that? Here's the answer, or a big part of the answer. Let's go after fraud, waste, and abuse. Let's cut MCOs out of the Medicaid program and save a lot of money, which will cover not all, but in most states, it will cover most of the loss in federal dollars because of all that administrative waste that's going to be cut out. So the report says, as Rose said, never let the Churchill quote, never let a crisis go to waste. And this is such an opportunity. So this report is extensively cited. I give a cite for it here, but it's extensive citations. It's reasonably scholarly. It was prepared by a team of physicians, researchers, advocates, and a medical student who spent, and I say we, I was one of them, who spent the summer exploring the limited research that's available and also what the states bucking the trend toward MCOs, including Connecticut, of course, have experienced. And the team included your own Kip Sullivan. It was a pleasure working with him on this project and other folks. The report recommends replacing MCOs with fee-for-service or preferably managed fee-for-service as the Connecticut model provides to both save money and improve access to care and accountability. And I do emphasize managed fee-for-service because that you really do want to coordinate care. All the things the MCOs said they would do, they never really did. But if you have a true system of care coordination where providers are paid extra to coordinate care, in our state, we also, the ASOs who are doing that as well, providing some intensive care management, case management, you really can get a handle on people with complex, uncontrolled medical conditions. The highlights of the report are that states relying on MCOs can reduce their overall Medicaid MCO expenditures by 10 to 17% just by replacing them. And that could be with just plain old fee-for-service, not managed fee-for-service. But the savings mostly come from avoided administrative costs of the MCOs and also from improved care coordination if the state chooses managed fee-for-service. One of the things the report notes, and this is based upon Millman, which is a very respected auditing agency and entity in the healthcare space, based on their data, MCOs on average consume 13% of the state Medicaid payments they receive for their own administrative costs and profits. Remember, Manette Health said, representing the industry, that it was 5.9%. Not really. It is more like 13%. And that's in addition to the administrative costs the state must itself incur to oversee the MCOs. That's not nothing. Overall, Medicaid administrative costs will be far lower if the MCOs are replaced with direct administration by the state, or if preferred, through contracting with ASOs. As I noted previously, we've saved over $4 billion since jettisoning them, and for a tiny state, we have less than 1 million Medicaid enrollees. I'm sure you have more than that in Minnesota. And the other thing in this report is it does a very nice job. I can say this because I had nothing to do with this part of it. Analyzing every state in the country and how much, if it's an MCO state, doesn't help in Connecticut because we're already not an MCO state, but for all the MCO states, 42, it goes through and analyzes how much could be saved on the low end and the high end from the conversion. And in the chart at the back for Minnesota, it says $690 million on the low end and substantially more on the high end. And there's certain assumptions for high and low, which are all in the report. But you can see a lot of money can be saved, and that can go a long way in addressing the federal cuts that are coming. And lastly, here is the report noted that you can do this quickly. One of the arguments states will argue, and they have argued, is we just can't, there's no way we can do that. That's a complicated thing, and it would take us years to do it. Really? Connecticut was announced, and 11 months later, it was done completely, including RFPs that went out, including the hiring of those 4 ASOs, initially 4, and getting everything up and running in 11 months. Oklahoma was even faster. They had a falling out with MCOs, were demanding more and more money, as always. And there was also a problem of them in a couple of counties of only having one MCO. Federal law requires there be, in general, requires there be a choice of MCOs. So they said, they bit the bullet and said, well, you're out of here. And the conversion was done in 4 months, based upon a small PCCM program like we had in Connecticut and making it statewide. So the argument that we can't do it because it would take too long is not true, especially since the federal cuts that are going to really hit are really more like 27 and even 28. So there's plenty of time to do it. This is just a slide showing. Now, this is from 23. I don't think it's changed. You can look at Minnesota and make sure you agree that it's properly dark blue. But I think we're at the same place. And so, frankly, we're looking to find other states to join Connecticut and change this map. And I think that's it. I think I'll stop sharing. Are there any questions?
Thank you so much. I invite you all to turn on your screens, and I see a whole bunch of people have turned on their screens. Can you use the little react on the bottom of your screen to raise your hand if you have a question, and Bahia and I will take care of monitoring the questions. We have about 15 minutes.
We had a few come through the chats.
Okay.
So I'm just going to go back to the chat, and I do see hands raised. But just to go in order, let's see. Somebody asked, did Connecticut have both privatized Medicaid and simultaneously a small number of Medicaid patients classified in Minnesota as disabled who were on fee-for-service? This is the system we have right now in Minnesota.
Yes, that's exactly what we had. Not so small. The entire elderly disabled population was in unmanaged fee-for-service, while the child and family population, pregnant people, they were in what was called then Husky, whatever, doesn't matter what it's called. They were in the capitated managed care system. So that, yes, we were the same as Minnesota, and there's several states like that too.
Thank you. The next question in the chat from Paulo: what have been the 2 to 3 top decisive elements that caused Connecticut to move from MCO to the current system?
The top 3 causes of that are media, and the third one is media. There obviously were serious problems in the delivery of healthcare in terms of access to services, both not find a provider and the prior authorization aspect, and issues of cost, both the total costs, always demanding more money, and the low medical loss ratios, meaning a lot of money not going to healthcare. And lastly, accountability. That a large part of why we won was publicizing all of this, but particularly the last piece, that we emphasized that they are taking at the time, and Far State was a lot of money, they're taking about $600 or $700 million a year of the taxpayers' money, and they don't want to be accountable for it. And we not only did we constantly say it over and over again, but we got politicians to say it. And we got, the lead newspaper to take out an editorial saying it, and saying, well, if they don't want to be accountable with the taxpayers' money, they shouldn't get the taxpayers' money. But the point was, it was all about making that become public so people would start understanding it, such that by the time the governor came in 2010, 2011, we had basically, set the climate, right? So that everybody was talking about this. Everybody's talking about that this is not working. And we need an alternative. And we were offering an alternative. So it really was the publicizing of those three pieces of poor quality services, expensive, and a lot of it being wasted, and lack of accountability.
Thank you, Sheldon. I'm thinking, and yeah, I think we can go to hands raised. John Crossan.
Yeah, thank you, Bea, and thank you, Mr. Toubman, for your presentation. I actually have two fairly simple questions. Number one, do you look upon the deprivatization of Medicaid as a stepping stone to getting Medicare for all? And number two, how did you get all of your citizens to be actively advocating with their legislators to push this?
The first answer is easy for me as a person, that I definitely see the deprivatization in Medicaid the same as deprivatization in Medicare, which of course we're going the wrong way at the moment, and generally that the argument for private for-profit capitated insurance companies running Medicaid running medical insurance in a fragmented system cannot really be defended. So I personally do see it that way, as if more states go to non-privatized Medicaid or non-capitated Medicaid, and we hopefully, and I am part of a group along with Rose, working on the Medicare Advantage thing, pushing back there. If we can push back there, maybe, obviously not in the current administration in Washington, but in a different one, that maybe we will make the case that we really can move on to something that's a national system. What was the second question? Oh, how did I get citizens? Yeah.
How did you get all your citizens to be strongly advocating with their legislators to push this?
I wouldn't say it was all. It was hard. We tried to find stories. And when we found the stories, we did a lot of, like that story of the person with the broken leg, we did a lot of publicity about it, because that's the way that hundreds of thousands of people see that, right? So more so than that, we did have those people tell their stories, and providers were really, really important. That providers are, of course, more in a position to do this, to speak out. And we did have a lot of dog and pony meetings with groups of providers, particularly behavioral health providers, to educate them about what was going on and how they can weigh in. And so when there were hearings on relevant bills, or even just informational hearings about issues, we could get people to turn out, and we did. But I would say it wasn't a lot of individual folks. It was more publicizing stories we did have.
Okay, thank you.
I see Teresa Delata up next on my screen. Teresa, do you have
Yeah.
a question?
So, you know, I understand, how the system is working and with insurance companies managing Medicaid. But how do you speak to people like I am on Medicaid? I did not take one of the offers to have it managed through an insurance company, right? Because I think that's not right. But it's hard to have these conversations with people because they're like, the insurance companies offer them silver sneakers or something else. And it's like, but they're denying you care. And, it's difficult to have these conversations in language that people can understand about how, insurance companies managing their Medicaid is actually harmful to them. Do you have any words of advice on how to have these conversations that are getting the point across, but in a way that is, not as jargoned, or you know what I mean?
Well, the silver sneakers is a Medicare Advantage, I think, ploy. And the other thing is the gift cards, the $100 or 125, whatever it is. And that is really hard. I mean, that's Medicare, not Medicaid, but what's the difference? And
Well, and a lot of those who are on Medicaid are also receiving Medicare and getting sucked into these Medicare advantages. So, I mean,
right.
it's all.
Yeah, and I'm for that. It's relatively other than the sneakers and the gift cards, you are gaining nothing. You are gaining, if you're on Medicare and Medicaid, you are gaining absolutely nothing, and you're being lied to because I mean we filed a complaint against United Healthcare a year and a half ago because they were taking out full page ads in the main newspapers and on TV, which said if you choose, it was directed to dual eligibles, and it said if you choose our Medicare Advantage plan, you will then be able to get, and the things they listed were things that people already had under Medicaid by definition. And it wasn't a mistake because it was directed at people who are on Medicaid. So it was fraud. It was directly fraud. And it's hard because of the not having the megaphone, but basically it was fairly easy once we talked to people to explain you're not getting anything there other than the gift card. All the medical transportation, the dental, the eyeglasses, that's all covered now. You're not gaining anything. They're lying to you. That was relatively easy. The dollar thing, the gift card, for somebody's low income. And what I try to do with that is say, it's great that right now you're relatively healthy. It's wonderful. But I can tell you stories, and because I have them, of people who, they did it for the card, and then they had a stroke or they got cancer. And now it's a nightmare. And would you give up the $100 a month to get access to quality, life-saving care in a timely way? Of course you would.
Thank you. I think we have time for just one more question. And Sharon, I see your hand up. And you're still muted, Sharon.
That early on you had sued the state. Who sued and who paid for it?
So it was, I worked at Legal Services at the time, and it was my program, New Haven Legal Assistance, and a sister organization, Connecticut Legal Services, two legal aid programs. And we combined our resources, and it was not, there was cost to it, right? And we brought as a class, it was the first class action in the country against a Medicaid MCO. But we did get waivers of certain fees, and we had a lot of support in the community in terms of my executive director and their executive director and our respective boards. And people recognized this was an important thing for our clients. It came to us. I mean, I wasn't looking for this thing. It came to us because we were getting complaints about access. It was very specific. Access to behavioral health services for children. That's where it started. And what happened, I mean, just to tell you about one of our plaintiffs. So that lawsuit, which was brought as a class action against the state Medicaid agency and the second largest MCO, I think it was the fourth largest MCO in the country at the time. We focused on behavioral health. And one of the clients was 5 years old, and she had been sexually abused, and she, was having a lot of issues, and the therapist was trying to help her, and the insurance company said, 5, you can have 5 sessions. So, that was very sympathetic. People could relate to it. There was no real response to that, how to justify that. So, I mean, it was not cheap, but if you're motivated and there's support and you do things reasonably efficiently, it's possible to bring a case like that.
Okay, thanks.
Thank you. Oh, anything else, Sharon?
No, I just said, okay, thanks.
Thank you so much, Mr. Toubman. This tracks really well with the things we're trying to teach our advocates here in Minnesota, and it just has been extremely helpful to hear this explained once more and give us some thoughtful areas to pursue, especially the media piece, I think. I wonder next up, Rose Roach is going to talk to us about why we need a similar approach, the patient-centered care direct payment bill here in Minnesota.
Yeah. Hi, everybody. Back again. Thanks, Sheldon. It's been a real honor to know Sheldon for a while now and to be working with him on a national level on some of our work on Medicare, as he announced earlier, but also helping to work on this national work where there really is a belief that the fight is in the states right now, and this deprivatization of Medicaid is absolutely a stepping stone towards single payer, and it could be a tipping point if we could get a substantive number of states to begin to deprivatize Medicaid and show that actually this can be done much better, much more cost effectively and efficiently without the private sector in the middle of it. I am going to hopefully share my slides now, just a couple of them. And let's see, are you all seeing the slide or are you seeing my notes? Oops.
We see your notes.
Hang on a minute. Now do you see the slides? Or is it still the notes?
It's still the notes and the slides.
Okay. So I never know in this darn thing. It drives me absolutely crazy, everyone. So please forgive me. Let me see. How about that? Is it still the notes?
Oh, perfect. Nope, it's perfect.
Oh, shoot. I thought somebody said it was the notes. Okay. How's that? Is that okay?
Yes.
Yep.
All
You
right.
got it.
All right. So I want to just take a few minutes to take a look at the impacts of HR 1 here in Minnesota specifically, and how we can learn from Connecticut, what Connecticut has experienced in moving towards deprivatization of our public health programs. So HR 1, just in general, pushes over 16 million people off of Medicaid and off of the Affordable Care Act. It slashes $1 trillion from healthcare over the next 10 years. It raises healthcare costs for millions of working families and the lowest income Americans. As I said earlier, we will all be impacted because our healthcare system is actually a healthcare marketplace. So therefore, these moves will significantly impact the system as a whole. There we go. The bill allows the advanced premium tax credits implemented during COVID to expire, exposing recipients to likely prohibitive out-of-pocket premium costs that include both the premium itself as well as rises in other types of out-of-pocket payments. In Minnesota, this is going to impact about 89,000 Minnesotans with premium increases of almost $200 a month. The cruelty of the bill in relation to treatment of immigrants is absolutely horrifying. HR 1 prohibits Medicare, Medicaid, and CHIP, which is the Children's Health Insurance Program, coverage, as well as ACA tax credits for many legally present immigrants, including refugees, asylees, and people with temporary temporary protected status, certain victims of trafficking, and people with DACA status, while shifting costs to states by not allowing states to receive enhanced federal funds for emergency care to immigrants who are ineligible for Medicaid due to status, further segmenting us into these categories of who deserves health care and who doesn't. And it isn't just cruel, it puts all of our health at risk because, as we all know here, health is public. Minnesota expanded Medicaid under the Affordable Care Act, and in doing so, Medicaid has been covering about 34% of all births, 32% of all children, 16% of adults between ages 19 and 64, 42% of working age adults with disabilities, 13% dual eligibles, those who have both Medicare and Medicaid, and 53% of all nursing home residents. 64% of Medicaid in Minnesota is funded directly through the federal government. So you can see how devastating these cuts will be. This is a snapshot of Medicaid and Minnesota Care, which is our basic health program under the Affordable Care Act that happens to cover people that are making more than the Medicaid top federal poverty level amount, which is 138%, up to 200%. So our state has two public health programs that we're looking at here. So for Minnesota, HR 1 means as many as 250,000 Minnesotans will lose access to health care, including 50% of children in rural Minnesota. At least $500 million in lost federal dollars to start with, but please remember that these cuts are cumulative over the next 4 to 5 years, and they will therefore expand over time. KFF, what used to be called the Kaiser Family Foundation, they now just go by KFF, has estimated Minnesota could lose as much as $1.4 billion annually. $11 million is cut immediately for cancer screenings, birth control, and testing for sexually transmitted infections. I do want to mention the realities of these new work requirements that we're hearing a lot about in the news for Medicaid recipients. You can see here that 92% of Medicaid recipients already are working full or part-time or are in school. The remaining 8% are either retired or not working. Medicaid is not something you receive as if it's a check that you get in the mail every month. It's a healthcare access program that allows you to seek medical care when you need it. Working and still qualifying for Medicaid, which means these workers' income is below 138% of the federal poverty level, seems to me to be much more the problem than the 8% who aren't currently in the workforce for various reasons. So what are we going to do to keep Medicaid and Minnesota Care whole, or at least mitigate as much of the harm coming as possible? Well, here's the options that our legislators are going to have to look at. Cut eligibility of the program, cut the benefits of the program, cut what are already way too low reimbursement rates to providers. We could raise taxes. Now, I wouldn't have a problem if we did that for the people who actually saw a windfall from HR 1, I'd be just fine with that. But an overall, tax increase is not going to be very easy to do, and it's going to be hard on families, right? And the middle class and the lower class. Cost shift from other necessary programs, take money from Peter to pay Paul, right? Or ding, 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 we could actually remove the health insurance companies, these managed care organizations, from medical assistance and from Minnesota Care, and we would take that money that we're saving and we would actually use it for care of the recipients of the program. We could even look to do like Connecticut did for some reimbursement rates, increase them to make the network broader so more and more providers are able to take Medicaid patients, and we could see an increase like they did in Connecticut in actual quality of care. Please note that back in 2022, there was a headline in the Star Tribune that said that the HMOs made $675 million in profits from Minnesota Care and medical assistance, which is the name of our Medicaid program in Minnesota. Remember, they're all nonprofits. So you take that for what it's worth. That's an awful lot of money. Medicaid privatization, just a little bit of background here. I'm going to go through this pretty briefly. In Minnesota began in 1981 with a gentleman named Paul Elwood. He's sort of known as the father of health maintenance organizations, HMOs, and he sold the Minnesota Department of Public Welfare, which is now our Department of Human Services, DHS, a rigged privatization proposal. In submitting that proposal to what is now CMS, the Center for Medicare and Medicaid Services on a national level, Minnesota led the nation in pushing to privatize public health programs. By 1983, enabling legislation is passed in Minnesota, giving the state agency the authority to designate 3 counties to be privatized as part of a demonstration project. And by December of 1985, approval to implement those that privatization scheme in those 3 chosen counties takes place, one of them being Hennepin County, and it is granted, and we're off and running. Minnesota does seek a federal waiver in 1987 to extend that demonstration, but is actually turned down at the federal level. However, that very same year, Congress begins to get into the game, and they enact legislation that permits privatization to continue not only here, but anywhere in the United States. In 1992, our state agency overseeing the program attempts to do a comparison of HMO spending, or MCO, against non-privatized counties, only to have that study suppressed by the same agency due to the cries of the HMOs. The suppression of the study garners a headline in the Minneapolis Star-Tribune back in, you can see here in 85, if I remember correctly, noting that a study raised concerns about how HMOs serve the poor, and it fell on deaf ears at the Human Services Department. In an internal DHS memo indicates that basically why the HMOs wanted the study suppressed, and that document says documents obtained by the Star-Tribune include a memo from a department staff member expressing concern that the HMOs had responded to the upcoming study by, quote, taking the offensive and believing that, as usual, DHS will cave in. The memo also said that some HMOs have a vested interest in keeping information from DHS because a large profit currently is being made, which would be revealed if the data were submitted accurately. So this is just a real problem, and I think it clearly makes the case that they're making money off the program. So fast forward a decade from 1994 to 2004, and you can see here, this is after the suppression of the study 10 years earlier, that, DHS admits that they have no idea if privatization has actually saved any money in the program. This just feels outrageous. It's public tax dollars. We absolutely, as Sheldon also said, we deserve to know how that money is being spent. When we give them the money for healthcare, we want to know that it's actually going to healthcare. So as we struggle to estimate the cost of Medicaid privatization, because it's really hard to get that data, it's all protected behind a contractual proprietary clause. It's a little bit of a mess, so it's really hard to know. We do know that the industry plays games with, again, as Sheldon talked to us about, medical loss ratios and what's classified as actual medical expenses versus administrative expenditures, which is why we believe using a 10 to 15 so percent for administrative costs and overhead is absolutely a fair percent for calculating potential savings once we remove the MCOs from our Medicaid and Minnesota Care program. We know that from all the work that's been done in Medicare and even from this national report, the blueprint report on Medicaid deprivatization that PNHP did, they actually said it could be as high as 17% could be saved. So we think that this puts 2 nails, strong nails in the MCO coffin. Connecticut led the way and has demonstrated that what we would call an HMO MCOectomy saves money. 15% of taxpayer healthcare dollars are being wasted on unnecessary administrative costs and overhead that does nothing but create barriers to care and obstacles for payment to providers, and that the HMO privatization proponents have completely failed to produce any evidence to the contrary. So we couple with deprivatization plan options that are due to the legislature next year from DHS. DHS with Senator John Marty and Representative Tina Liebling's bill on deprivatization, which is called the Patient-Centered Care Act. We are pretty well ready to go once those plan options are presented in 2026. The bill begins the process of moving Minnesota's Medicaid and Minnesota Care programs to a direct provider payment system, removing the unnecessary middlemen, the managed care organizations from our public health programs. The bill also prioritizes funding for care coordination done by care providers, not middlemen, collaborating with community clinics to do outreach to people who are not receiving the care they may need. The Patient-Centered Care Act begins to build our public health infrastructure. And I just wanted to share a little bit of an outline of our work over the next 12 months so you can see where you might be able to help. We want to educate and engage legislators as well as the community in this campaign to deprivatize Medicaid and Minnesota Care, and do that through one-on-one legislator meetings, as I referenced earlier, strategize with them on this inside-outside the Capitol plan for moving the bill. We need to be writing op-eds, we need to be sponsoring town halls, and within the political party arena, we could even look to pass deprivatization support resolution. So there is something for all of us to participate in. Now, I know that a lot of people think single payer, state or federal, is all pie in the sky, right? I get it. This is a heavy lift. It's a hard time. But this kind of change, we know, is simply the only way, because there is no other way to fix how healthcare is equitably and affordably delivered. So we have to use this time to play defense, but to also build the campaign, to implement the stepping stones, and to provide a vision of hope for what's possible for a healthcare system grounded in our common humanity. And that starts with kicking the money changers out of the temple and removing the HMOs and MCOs from our public health programs. So with that, that gives you a little bit of an idea of what we're working on.
Wow. That was just amazing. We have just about 3 or 4 more slides. Do you want to take a couple minutes for questions, Rose? Does anybody have any?
I mean, I'm happy to answer, 2 minutes, because we at 7:45, we want to respect
Right, and we
everyone's
wanna have
time.
on
So
time.
if anybody has any specific questions about how to do these meetings and how we can help you get those meetings going, and between me and Kip and Ann and Dave, there's a handful of us that are happy to join you at those meetings, and walk through all of this stuff with the legislators, because they don't know this stuff because they got a lot on their plates, right? It's hard to know real deep policy on almost anything because they have to deal with every issue that comes before them. So taking the time to really walk through this with them has been so wonderful, and they really do seem to get it. I mean, they're like, hey, this is something we should pay attention to. We even met with the health policy staffer out of the governor's office, and we were told, I think, what is some of the best news we could get out of the governor's office, which is they're anxious to see these deprivatization plan options that are going to be coming forward in 2026 from DHS, and that they have absolutely not taken the idea of deprivatization off the table. It is on the table for consideration. So I think that's a real positive for us here in Minnesota. I don't think there's any questions, Ann, so you go right ahead.
Okay, thank you. Let me see from currents. Let's see if I can make this work right. So let me talk about, just to wrap us up, I want to give a great big thank you to all the people who volunteered for the events that we have done this past year so far, and we have a few more to go. We've had great participation from both Healthcare for All Minnesota and Physicians for a National Health Program Minnesota chapter. We're trying to get out and be visible and talk to the public so that we can get them engaged and pushing this message up to our legislators and candidates as well. We've had a presence this year so far at rallies, at festivals, at parades, at the state capitol, at the fair, and more. and more than that, both in the metro and in greater Minnesota. All of this takes dozens of volunteers and lots of planning. Many of those who consistently volunteer stepped up again and did even more. And we had a number of new volunteers. We thank you especially and hope it was a good experience for you and that we will see you again. So this is the work of both educating the public and the voters, as well as building our base of support for change. If you haven't yet volunteered for an effort for an event of any kind, don't be afraid to step up. I encourage you to consider giving it a try. It's great practice for talking about our issues. It gives you a feeling of accomplishment and contributing to the campaign to eventually win the Minnesota Health Plan. We have a number of events coming up in the next month or two, and these events are also on our calendar, which and the website is on another slide. It's in our monthly newsletter and in email notices coming out from Healthcare for All Minnesota. We'd like you to let us know of any events that we should either post on our calendar, put in the newsletter and promote attendance, or participate as presenters or for outreach. This Tuesday, we have a wonderful presentation from our partner organization, Physicians for a National Health Program Summer Interns. These are medical students and students in public health, allied health fields who take time to study this issue, and they are going to share their learning on this Tuesday, September 30th. I'm hoping that Bahia can include how to register when we'll send an email out after this meeting this evening. And Saturday, October 4th at 3 p.m, I'm giving a talk at the unit for the Humanists Minnesota at the Unitarian Society on Mount Curve, Minneapolis, called Fixing How We Pay for Healthcare. The full name is Now That We've Tried Everything Else, How About We, do what we know will work. Sunday, October 19th at 4 p.m, again, same topic. And I'll be talking to an Indivisible Left at the Elko New Market Library. On Thursday, October 23rd, is our fundraiser. More on that from Bahia. It's at the Bad Weather Brewing in St. Paul. It's going to be fun. You should come. And on Saturday, October 25th at 11 a.m. is an event called Day of the Dead with a partner organization, Copal, and that's going to be in Old Town Mankato, staffed by our healthcare activists, Healthcare for All Minnesota activists in Mankato, and our partner organization, Copal. And I'll mention an event, a national event. I know this one's maybe a little bit out of reach for some, but I know Rose and I are going. And November 1st through the 3rd is the Physicians for a National Health Program National Conference in Washington, D.C. And for the first time, we are going to be staying over till Monday for a lobby day to talk to our members of Congress about our number of concerns, obviously, with potential changes that we see as the wrong direction with our Medicare program and cuts to Health and Human Services and a couple of other issues. And of course, the big ask will be a national health plan, which is where we all believe we need to go. So let us know again of local events that we should promote. And also, if you got this invitation from somebody else and you are not yet on our mailing list, please make sure that you can either let me know and I can get you into our database, or Bahia, or go to hca-mn.org and put your contact information in. This gets you into our database so we can stay in touch with you. Then one last thing I'd like to mention is that in the modern era, government is how we take care of each other in many cases. We, the people, are going to have to show up until we reverse the actions already taken by the current regime and those that are pending, and put power in the hands of leaders who believe in freedom, democracy, and prosperity for all. So a big event coming up October 18th is going to be another No Kings rally. There are going to be various locations around the state and around the country. They're sponsored mostly by Indivisible, 50501 or 5051, People's March, and other organizations designed to push back on a regime that is explicitly backing away from its responsibility for us and for our democracy. We need your help to spread our message. Please see this slide when you get the slides in the mail for our social media sites, addresses, and content for you to share. It's a really one of our least expensive and possibly one of our best ways to get the message out there. Please consider setting up accounts on at least one, if not more than one social media platform so that you can interact with them and amplify the message of healthcare financing, a healthcare financing system that works for all of us. You can go to YouTube anytime to our Healthcare for All Minnesota channel to view any of our past educational offerings and meetings, and also share. And please also like, and so that site gets a little bit more visibility. Anything that we've recorded should be on that site. We need a lot more followers to increase traffic on these sites. Please read and share our monthly newsletter. Also check Healthcare for All Minnesota and the PNHP Minnesota websites. Updates are ongoing. Look for articles and information that we can post on our websites or on social media and let us know what we should be putting out there. Also check for legislative updates. The Minnesota Health Plan website is mnhealthplan.org. It's updated and just loaded with great information, including an extensive frequently asked questions section. And Healthcare for All Minnesota is now on Blue Sky. And it's easy to set up an account by going to bluesky.com. So other useful websites are listed. I send these out every month, but just in case you have a chance to add these to your, I'm sure already overflowing inboxes, but they're all very good, very informative. Also will make you, I think let's say, highly motivated to engage in this fight. So I won't go over the list, but all of them are very good and longtime advocates for fixing how we pay for healthcare in this country. And thank you again for joining us this evening. This is my contact information if you need to reach me, and I'll let Bahia wrap us up this evening.
Perfect. Thank you so much, Anne. Chock full of wonderful information. So just a few things before we wrap up. First of all, thank you for joining us tonight. Sheldon's presentation was phenomenal. Rose gave some incredible insight, and the same for Anne. We just had a really great lineup for tonight's meeting. The second, for any new folks that were able to join tonight, we hope this meeting has been fruitful, and we hope you come back for future quarterly meetings. We advertise them well in advance so people can get them on their calendars. And then in addition, Anne mentioned our upcoming fall fundraiser that'll be taking place on October 23rd at Bad Weather Brewing. We did send an email blast with the save the date. That also includes a Google form so we can collect RSVPs. There will be a food truck at the site. We're also going to be baking some goods and bringing those with. There will be a place to get alcoholic and non-alcoholic drinks. We'll have a speaker series lineup that will be a combination of healthcare advocates, healthcare leaders, and professionals in this space, legislators. And so we hope that you can join us for that wonderful evening. We're very much looking forward to our fall fundraiser. So I just dropped the RSVP link in the chat so you can sign up. More email reminders will go out about this.
And we also have music from Dr. Dvorak, who is a wonderful longtime advocate in this space, and a sing-along, so you should come.
Yes, please. It's going to be a wonderful evening.
Yeah.
And then I also want to mention, we can't do this work without wonderful contributors like yourself. We rely very heavily on donations, small time donations, large donations, and everything in between. I know I already dropped this, but I'll drop it again. This is our general donation link that's right on our website, www.hca-mn.org. And the link I put in the chat takes you directly to our donation site. If you can give just $5 today, that's perfectly fine. We welcome it. If you can give more, that's wonderful. You have the opportunity to also be a one-time donor or a recurring donor, so you can provide your generosity all year round. And so we welcome anything that you can provide. We very much thank you for your work, for your curiosity, and for being champions in this movement. It means so much. And then lastly, this was recorded, so we're going to go ahead and share this out afterwards. We'll have it uploaded to our YouTube page, and we'll also share out the slide deck so everybody has access to all the great information that was shared tonight. With that being said, it looks like we're going to end a few minutes early, which is always a good thing. So thank you everybody for joining us, and have a great night.
Thanks, Sheldon. Bye, everyone.
Take care.
Could our
Bye-bye.
presenters stay on for just a minute after we end our meeting?
Yeah,
Sure,
we sure
I can.
Okay.
It's later for Sheldon out there